Good morning, good afternoon, good evening, everyone. We'll get started in just a minute. All right, we'll go ahead and get started. Hi, everyone, and welcome to this month's Washington Healthcare Facilities Community of Practice. My name is Ryan Kronk, and I'm with UNC, and we serve as a secretariat for the community. And as you're joining the webinar, please add your name and organization to the chat box if you'd like. And today's webinar is focused on actions implemented at healthcare facilities in Uganda to improve hand hygiene. So first, I'm going to just quickly for our agenda, I'm going to give a few announcements and reminders, and then I'll turn it over to our speakers, Shillah and Maureen from IDI at Makerere University, who will give us a presentation on hand hygiene and IPC in healthcare facilities in Uganda. We'll then have a question and answer session, so please be sure to use the chat box to ask questions during the presentations or to let us know that you have a question you'd like to ask live. Other announcements, we have our next webinar in May. Lucy Tantum from the Water Institute will launch a brand new evidence map that's focused on WASH and essential environmental conditions in healthcare facilities. The webinar will be on May 5th at 9 a.m. Eastern Time, so you can go ahead and register for that if you'd like. That link will be in the chat. And as we mentioned at the last webinar, we've launched a working group focused on faith-based organizations that are working to advance WASH in healthcare facilities. Our first working group is going to be in May. If you're interested in joining, please let us know in the chat box or email Nikki. Her email contact is on the screen and in the chat. Would also like to remind you that next week you're able to virtually attend the Rome. There's a Rome event on faith-based organizations and healthcare facilities. If you go to the COP webpage, there's a landing page that you will be able to uh, join join the live stream if you're interested in that as well. As a reminder, invite your colleagues to join the community practice. There's a MailChimp. We will not spam you but give you all the latest and greatest updates. So please be sure to be on that list to get all the good news on Washington healthcare facilities. And we'd also like to invite you to contact us with ideas for speakers or topics. If there's some work you'd like us to highlight at a future webinar, we're always looking for new ideas. We're already planning out into the fall with some exciting new content coming up, but we'd love to integrate your ideas. We want to be a bottom-up community and hear from you all to respond to the needs of the community. So if you have ideas for speakers, topics, or webinars, please feel free to email us at WashingtonHCFCOP, and that email will be in the chat as well. So with that, we will now pivot to our speakers. We have Maureen Kesande who's the program lead for WASH and Planetary Health in Global Health Security in the Global Health Security Program at Infectious Diseases Institute, IDI in Uganda, and Shillah Nakato, the Senior Technical Advisor of IPC of Infectious Diseases. With that, I will turn it over to Shillah and Maureen.
Thank you so much, Ryan. All right, so thank you so much, Ryan, for the introduction, and thank you again for giving us the opportunity to speak at this COP. My name is Shillah, as Ryan has introduced me, and I'm going to start us off in today's webinar with a quick introduction on what we're going to speak about today. So today we are going to look at some of the actions that we have implemented over time but the focus is going to be on ABHR production and access in healthcare facilities for improvement of hand hygiene. Next slide. Okay, so I just wanted us to look at this slide first and get why we need to adhere to hand hygiene into our system, our head, think about it. It's always something with our hands. It starts in our hands, and then by the time you know it, you don't know how much we cause the patients, their caregivers, and people around them in terms of diseases, in terms of healthcare costs, in terms of everything that comes with hospital-acquired infections. Next slide. Next slide. But we will to this afternoon we are going to mainly talk about the importance of hand hygiene. We'll look a bit about some of the strategies we have implemented in Uganda across the different healthcare facilities. And then we will also speak about the infection prevention and control and the strategies that we have implemented. Then we will have some discussion. So to start, sorry, go back to the slide where you were. Thank you. So to start, we all know that healthcare-associated infections are a burden across the world. Ryan, could you go back to the slide you were projecting? Okay, the introduction slide. Yes, that one. Thank you. So we all know that healthcare-associated infections are a major burden across the globe. And so implementation of hand hygiene is really critical when it comes to prevention of the majority of healthcare-associated infections. And with that, we've seen quite a number of HAIs in different healthcare. And according to WHO, they quote about 30% of infections seen in ICUs. But also, they say that in 100 patients, at least 10 of them acquire a healthcare-associated infection. So hand hygiene is really key, but then we see that compliance of hand hygiene among healthcare workers is very, very minimal. And so, as we all know, it does not only come with maybe training healthcare workers, providing supplies, but we also understand that we need to put in some actions that target behavior change. So next slide. And so we will speak a bit about some of the behavior change actions that we have also implemented in some of the healthcare facilities. So I wanted to bring up this slide just for us to see what happens in healthcare settings. We did this survey anonymously without informing healthcare workers who were entering a healthcare facility to see if before they enter and start work, how many of them perform hand hygiene. And we have decided to anonymize the facilities where we did this survey. But you can see that not quite a number of them do remember that hand hygiene must be part of them before they begin their daily activities. So I just wanted to show this in relation to the slide that I've just spoken about. Next slide. All right. So why are we talking about hand hygiene today? One reason is that, like I've already said, it is really important for us to remember that hand hygiene is one of the key transmission channels when it comes to microbial pathogens in healthcare worker hands. And so the reason we are speaking about hand hygiene today and speaking about production of alcohol-based hand rub, the initiatives, it is really to show that to show how much we need to implement and how much we need to keep reminding healthcare workers when it comes to prevention of infections. It improves quality of care, and that is something that we all know, and also leads to minimizing hospital costs when we prevent infections, then we minimize or we reduce on the time that the patient spends in the hospital, or the extra diseases that they get, the additional infections they get during their care. And so we help them to minimize costs both on the hospital side as well as on the patient side. Next slide. Next slide. Okay, that one. Yes. So during our ABHR initiative, or alcohol-based hand rub establishment initiative, there's quite a number of things that we had to go through, number of steps that we had to go through before putting together the idea and, starting on the implementation of the idea. First of all, when we were trying to put together the concept of improving hand hygiene and ensuring access to hand hygiene products that support hand hygiene in healthcare settings, we first thought about the hospital leadership. How do we get the hospital leadership to understand the importance of this idea or this innovation? And then we worked with them to reactivate the IPC, or the Infection Prevention and Control committees, focal persons, and then worked with them to conduct a baseline assessment to understand how the practice were being implemented in relation to IPC, as well as hand hygiene practices. And then we trained these committees, then worked with them to develop their facility-based work plans, which included hand hygiene monitoring, ABHR use monitoring, and then follow-up assessments and implementation of actions, which depended on the gaps that we identified from the assessments. Next slide. Yes. So the assessment, the previous slide, the assessment and all those actions brought us to the innovation, to the innovation of how do we get healthcare facilities access products that can support them to improve hand hygiene and infection prevention and control in healthcare facilities. So one of them was local production of alcohol-based hand rub, and this was done in different sites, like Maureen will come in and highlight. And one of the things that was really key is to ensure this production was consistent, and supply and distribution was also consistent to where there was needs. And then healthcare workers were trained on how to use the ABHRs. And then we had to integrate hand hygiene monitoring into IPC program and the use of ABHR. And so we monitored utilization. We also monitored compliance with hand hygiene after ensuring access to the hand hygiene, to the ABHR. And then we also supported facilities to place the ABHR at different points of care, especially where healthcare workers could easily access the ABHR. And then also came up with an idea of distributing to different other high-risk areas, which were hospitals, but also inclusive of other community locations where ABHR was mostly needed. Next slide. Yeah, and so what was the reason for this, for ensuring for ensuring access to ABHR in healthcare facilities and other sites, high risk sites, like I said. One, we mainly thought that we would at least provide more supplies of hand hygiene products, and because of the shortage of hand wash basins in hospitals, in wards. We thought that ABHR would complement the hand wash basins and the soap, the lack of the soap. And then also there's quite a lot of a lot of work, and often healthcare workers get too busy, and sometimes they end up missing out on accessing hand hygiene areas, going back and forth to wash hands. So we thought that this would be very convenient. The fact that they are able to put the ABHR bottles or dispensers on their trays as they move around, on their trolleys as they go around to support patients or to treat patients. So we thought of a convenience, access, and then being that they are very few and they get tired, they easily forget. So the fact that they had at least pocket containers or pocket bottles, they could easily remember that, okay, they can use an ABHR bottle that they have on them. And then also considering patient needs, they have to prioritize to use ABHR before they touch different patients and after they go around different patients. Next slide. All right. So for the local production of ABHR, I think, okay, Maureen is here. So I'm going to invite Maureen to take us through this slide, the different approaches that Uganda used to ensure that there was production of ABHR in different sites, and then distribution and access at different healthcare facilities and other sites. So allow me to invite Maureen to join in here. Maureen, over to you.
Maureen, you're muted.
Yeah, thank you so much, Shillah, and thank you so much for the preamble you just provided regarding our journey in hand hygiene and also how we leveraged the local production of alcohol-based hand rub, where we relied on the WHO protocol and looked at different literature from other places to see that this can also be adopted for Uganda. And we actually ran a proof of concept with funding from the US CDC. So it gives us pleasure to be able to share this. I know it has been met by a couple of people on this platform, and we constantly welcome the opportunity to share this information. So very quickly, we looked at setting up this approach from the level at the district level all the way up, and looking at what was the role of the district. And in many countries, this can be a district, this can be a county or a province, or whatever the case it may be. And then you're looking at what is the role of the partner that is supporting this, as well as the storage. How do we take care of the storage and the supply chain for the alcohol-based hand rub through a district-led approach? So at the district space, which is the smallest unit of the government, would be for the district to provide space. And this is, of course, for ownership and for institutionalization, so that this space can be used for the production unit, where in terms of production, there's quality control done by the district as well. To make sure that it is meeting the WHO standards of the content of the alcohol-based hand rub that is being produced locally. And so in terms of supply chain, the district also supports with a chain of custody, making sure that the supplies are available, and also making sure that utilization is garnered through IPC mentorship programs, where we talk about hand hygiene within the health facilities, garnering a lot of buy-in for use of hand rub and when to use hand rub. And the partners, in this case, it was the Infectious Diseases Institute, where we come from within Makerere University, with the funder, which was the US CDC, to provide supplies quantification. What do we need to be able to set up this structure? How do we establish and functionalize these production units? How do we build capacity of district staff to be able to produce their own alcohol-based hand rub from scratch using the supplies that are available on the market. We also support, of course, from the partner end with the packaging, the branding, to just, work out with the districts on how these are going to look like. And we also provide the buffer supplies or replenishment and monitoring consumption at the sites to support the Ministry of Health, really, and also engaging the medical stores to look at the distribution to the community if the intervention goes across the community locations, because for WASH in healthcare facilities, some of the times we're only looking at health facilities, but we realize that there were community-based health workers and other community sports that needed support, especially during outbreaks. For storage, of course, we look at the raw materials, and that is at the district stores, the issuance of the finished product, and then support for distribution. So what is the existing network for distribution of actual essential medical supplies so that the produced hand sanitizer can also be put on that chain of distribution, and it is distributed as part of other essential medical supplies, and that takes off the cost of the partner of the district, but also becomes co-opted into the district costs. Next slide, please. How do we then, after we have set up this production unit, how do we ensure, first of all, production means that we're ensuring access, but then it's one thing to provide, but then it's the other thing to track utilization. So here we relied on the WHO hand hygiene observation forms, and this is what we show here. Most of us have interfaced this, where we monitor hand hygiene and look at how it is being utilized. Are they using hand sanitizer? Are they using the hand rub? And then also we also monitored glove use because it features in the WHO hand hygiene observation forms. So using these assessment forms, we're able to track what is the utilization before patient contact and also after patient contact and so on, according to the WHO hand hygiene observation form. In the next slide, we'll show some of the results. If you could go ahead, Nikki. Yeah. So this is the hand hygiene observation data, and I know this is just a snapshot. For any hand hygiene intervention, we must be able to track using audits. And we know very well that the best way to audit hand hygiene is by observation. And we were able to come up with this. And instead of using the 5 moments of hand hygiene, which would be the WHO guidance of how we track and audit hand hygiene, we just looked at 2 data points: before and after patient contact. And you can see that in the baseline, which is in the first table. So these, sorry, we didn't label this very well, but the first tranche is the baseline, the middle one is the midpoint assessment, and then that's the endpoint assessment. And we just scooped this out of one of the assessments that we did, which gives us a picture of how these look like following the hand hygiene intervention. So we noticed that before, of course, hand hygiene was happening, which is very good, but it was mainly with hand washing with soap and water, meaning that in the event that there is no soap and there is no water, there would not be any hand hygiene. But then with the intervention coming in where there is availability of hand sanitizer through local production, we noticed that at the midpoint, we had even more people sanitizing their hands before patient contact, which went up very, very significantly after patient contact. And we also see that the way people started using soap and water, it did not reduce to mean that soap and water had been replaced with alcohol-based hand rub, but it came with an initiative where there has been a training to indicate that we wash with soap and water when our hands are visibly soiled. And then, of course, use hand sanitizer between patients and etc., using the small bottles that are on their person to ensure that there is better compliance. So we saw a big jump there, but then it brings me to the end point where we saw big improvement in even the before, meaning that people or health workers were not even hand washing or sanitizing before patient contact. But we saw that by the end point evaluation, more people were conducting hand hygiene, although the numbers went down, and we shall talk about something about even provision of supplies, with capacity building and audits. We still see that sometimes hand hygiene compliance can go down. And we will talk about that later and the interventions that we put in place to answer some of these questions. Next slide, please. So when you look at the strategies that Shillah presented earlier, we looked at capacity building and sensitization, as well as training on production as one of the hand hygiene interventions that Shillah graciously presented earlier. So we have two areas: what was the target and what were the areas that we were looking at supporting. So we targeted hospital management for obvious reasons, because they really run the hospital, and everything that we're doing requires money. So this is where, inclusion in the budget falls, because sometimes when the administration and the leadership of the hospital or the health facility is not aware of some of these strategies, it might be difficult for these items to find themselves in the budget. There might not be a lot of buy-in for IPC WASH at healthcare facilities without the hospital management. That is very key, and I wanted to make sure that we talk about that. Hospital IPC committees, these are important because they keep the message running. They are reminders in the workplace for continuity of these structures. So there was need to build capacity of these IPC committees and reactivation of those that had died down. There's a tendency, and I know in many different countries we see this, and this just shows that there's a lot more activation and a lot more health workers and committees are more active during outbreaks, but then we tend to lose a lot of the attention when outbreaks go down. So we are trying to ensure, and it's a continuous process, that IPC is part of the daily running of the normal activities. And then, of course, selection of focal personnel are all what we call champions at each of these health facilities, build their capacity, sensitize them, and train them on alcohol-based hand rub production. The training was mainly targeting larger hospitals, because at smaller hospitals, is where we just distribute. And then we were mainly talking about ABHR production, the distribution, monitoring and utilization, and of course, hand hygiene compliance monitoring, which is key. Otherwise, all the effort falls through without any impact if it is not monitored, if it's not checked, if it's not evaluated. Next slide, Nikki, please. So as part of the strategies, there was also a need for us to come up with an IPC work plan. And here we have a snapshot of one of the hospital work plan. And apologies, we have names of people here, and those are actual names. So we do take responsibility, and we have had consent of these teams to be here in these slides. But the main point is that there's need for work plan development for IPC and WASH strategies or initiatives or quality improvement initiatives for our program to really stand. And so we want to know, in terms of leadership and organizations, do we have IPC committees? Are they meeting? Are they engaging top management in IPC planning and budgeting so that implementation can be easy? And what are the activities? So we describe the intervention, the activity, which means, okay, if we're talking about IPC committee meetings, are they scheduled? Are committee members active? How many members have been appointed? Have they received appointment letters? And what is the time frame in which some of these activities are going to be done? What are the requirements? What are the resources needed? Who is responsible? And when it comes to the IPC standard precautions, so this IPC work plan or WASH work plan will have very many objectives. And the first one, which is, of course, leadership and organization, this is just a snapshot. We also talk about IPC standards. And you can see at the bottom, there was hand hygiene as one of the activities appointing a focal person for local manufacture of alcohol-based hand rub. So a focal person is appointed, there's an appointment letter, and then the trainings have happened, capacity has been built. So those are parts of the work plan that IPC committees at hospital level would have, so that they keep the activities going and tracked and monitored. Next slide, please. Yeah, and again, it was just not enough to stop at training health facilities. One of the moves for which we applaud the Ministry of Health was joining hands with the Infectious Diseases Institute and other stakeholders to develop a capacity building approach, an e-learning curriculum for alcohol-based hand rub. So this is a module, is an 8-module course that we developed for alcohol-based hand rub, starting from the background of hand hygiene, the requirements, selections, quality assurance, and all this is available at on the e-learning platforms that we have. And the idea was that this would be institutionalized through the Ministry of Health, so that health facilities and IPC committees can take on this self-paced curriculum for production of alcohol-based hand rub. So the good part or the beauty of this curriculum is that it has a practical and also has tutors that have recorded, and we are able to have practicals, we're able to have self-paced modules that health workers can access, or IPC committees can assess and have this set up in each of the facilities as they do so wish, for as long as they have access to supplies. Next slide, please. So in terms of distribution, of course, we were distributing alcohol-based hand rub with the support of the national medical stores to the health facilities. And as I mentioned, it was not a cost that is incurred by the partner, but rather relying on the national distribution systems of essential medical supplies. We had the alcohol-based hand rub also placed on the distribution tracks and distributed as other essential supplies. In terms for community locations, it was quite tricky, and we continue to look at how other countries have done it, because there is no established distribution system for community locations. For example, outside the health facilities, how do we distribute to markets? How do we distribute to churches? How do we go to the mosques and other places? So with working with different partners, and we also worked with the IRC, and I know many of us have worked with, know about the IRC interventions in Western Uganda. So these are some of the people that we worked with in these kinds of interventions to see how do we go outside the health facilities. But I know today we are looking at health facilities, so I'll just focus the conversation to that. We provided wall mounts for mounting the ABHR so that it's visible at the entrances and at other points of care, so that it is seen, it's accessible, and even when it runs out, somebody is able to see that. We provide IEC materials, what we call posters, as reminders in the workplace, stock cards, and other hand hygiene audit tools as part of the distribution. So you don't just drop the jerrycan of hand sanitizer and walk away, but rather all these additional pieces are part of the entire distribution as well as capacity building. Next slide, please. One of the ideas that we realized is that actually the alcohol-based hand rub bottles can also be a source of infection. This was quite interesting to the team that we were working with, because we thought that if a bottle is carrying hand sanitizer, alcohol content 80%, and other ingredients, glycerol and others, how then does the bottle self-contaminate? But we realize that most of the health facilities are not aware of the need for cleaning and disinfecting the bottles. And this really posed the risk of infection because one alcohol-based hand rub bottle moves from one station to another, and there could be microbial contamination from just the direct contact during use. Quite interesting. And so we also had capacity building, and we looked at SOPs, which we developed for ABHR containers so that they are cleaned and disinfected before refilling, and there was a schedule to have health workers and the focal persons or champions make sure that according to these SOPs, the bottles are cleaned, they are sanitized, they are disinfected to avoid this microbial contamination. Next slide, please. One other interesting factor that we wanted to bring to this discussion was, again, this was discussed in one of the UNC conferences, I think 2025 or 2024 at the UNC Friday Center, where we discussed and we had a side event on how we use the population connectivity across borders during emergencies, especially COVID-19, to identify the areas or the facilities that needed to be beefed up. Let me also mention that the production of alcohol-based hand rub is not to replace the government initiatives or to replace the government supplies. It's just a buffer. So through these initiatives, and if I focus the discussion back to the population movement, so this is an assessment that happens that during outbreaks, or even if we want to check how population movement happens in different areas for a certain reason. And in this case, we were looking at truck drivers who were the first carriers of COVID-19 confirmed patients, and we were looking at their movement patterns. So these movement patterns helped us identify priority locations where we would place and make sure distribution of alcohol-based hand rub is a priority. The priority is to make sure that we are not providing alcohol-based hand rub in an unguided way. So this helps us to target and to also utilize the available resources and not to waste them. And so with the prioritizing, we're able to target the distribution to people that actually need it, to people that are actually going to have the highest yield of benefit of this intervention. So in this particular intervention, we had this assessment done, and we were able to identify where the majority of the stops are. So where would, in this case, the truck drivers stop the most? Where are the schools that most of the people go to? Where are the markets that are mostly on the way where people stop the most? Which facilities do people take patients? And so we were able to identify priority locations. And in the distribution of alcohol-based hand rub, we were able to just target those priority points and have the government, of course, also support the rest. And this helped us to prioritize. This helped us to have a better intervention. And we'll be talking about some of the papers that have come out of it to show that this was a very, very good intervention, especially during emergencies where you do not want to have a lot of resources being, provided without any guidance or without any assessment that has been done, but to help in the prioritizing of locations. So we identified points of contacts in these prioritized sites so that they are able to check on the stock, to make sure the bottles are refilled, to make sure that hand washing stations are functional at the entrances, because hand hygiene was one of the key IPC interventions that we were strengthening within these areas. And at the point of entry in the picture, this is at the northern part of Uganda going into Sudan, where we have the largest point of entry there. We were able to identify priority locations along these routes and provided the ABHR accordingly. Next slide, please. Yeah, so here I'll give it back to Shillah, and I hope that we'll continue to interact much more, and there'll be some questions at the end. Back to you, Shillah.
Thank you so much, Maureen. Thank you for that elaborate discussion on WASH and ABHR. Quickly, I'm going to take you through the infection prevention and control, mainly the improvement strategies that we implemented in the previous months, years. So next slide. Next slide, please. All right. So we did about three main we had about three main strategies, and these strategies were mainly focused on improving hand hygiene and basically the system. So one of the three main strategies that we implemented was implementation of adoption of and implementation of the WHO or World Health Organization multimodal strategy, and this focused on about 5 or 6 areas where we looked at how do we change the system, and in the changing the system, how do we provide supplies or tools that are required by healthcare workers to be able to adhere to IPC and in the end improve hand hygiene compliance. We trained healthcare workers, we monitored them, and we provided real-time feedback and agreed on actions to improve where they had gaps. And then we also provided some reminders in the workplace where we worked with them directly to ensure that these reminders were placed at different points of entry, point of entries and point of care areas where they could easily access them. And then at the end of the day, we wanted to ensure that we contribute to a safety culture and patient safety in the healthcare facilities. Then we also worked collaboratively with the Ministry of Health to design and implement quality improvement programs and projects. And one of the projects was improvement of hand hygiene. And so here, ABHR production in some of the districts came in handy because we identified gaps during the assessments, and then these gaps were used to come up with the projects. And then during the implementation of the projects, the hand hygiene projects and other projects, we provided ABHR, we provided IEC materials, we trained healthcare workers, and then we did many more things that were targeting to change the system as well as maintain a safe patient care environment. Next slide. All right. Then the other strategy was, again, collaboratively working with Ministry of Health and other implementing partners to develop a national IPC mentorship program. This program was implemented since COVID-19 through the years after COVID-19 until now. We have some facilities that are ongoing mentorship program. We all know that mentorship is a long time program, and so this program focused on mainly having simplified training modules that can be delivered during a continuous medical education at a healthcare facility for at least 30 minutes to 1 hour each time. And then it also focused on regular support supervision visits, regular monthly on-site mentorship, as well as monitoring, and then providing feedback that came from the supervision and the monitoring, and then also working to ensure that the gaps that were identified from the supervision and the monitoring were closed together with the facility leadership and the IPC teams of the healthcare facilities or the hospitals that were supported. And then this also was supported by, like I said, by the local production of alcohol-based hand rub, and we saw that those facilities that were really committed to implementing this program, we saw a lot of improvements in IPC practices, and then we also ABHR supported addressing some of the hand hygiene challenges, and then there was a consistent supply of at least ABHR, even though the other items were not there, but the ABHR was always there to support healthcare workers and hand hygiene. Next slide. Yes. So, and in the other strategies, like we said, it may not only stop at providing supplies, training and education. We know very well that IPC is a behavior change. It somehow feeds into a behavior change models, and so if someone has all the items, all the tools that they need to use, may have all of them, but then they may not be able to implement or do the actions as they're recommended. So we also came up with some behavior change modules that were mainly targeting healthcare worker attitude and behavior, and reasons why some practices are key when it comes to healthcare worker and patient safety. We also supported communities of practice, which some of these ones were driven by we are led by the healthcare facilities themselves, and so the IPC focal persons of some of those healthcare facilities were required to attend them and make presentations on the progress of the IPC within, or the status of IPC within their healthcare facilities. But additionally, like we already said, we continuously provided visual reminders, because the other thing we noticed with behavior is that if a healthcare worker does not either see a photo, a picture, or something that triggers them to remember to act or to do an action, then they will not be able to do something. So we provided reminders, and then we involved leaders for ownership and accountability. We involved leaders to take part in ensuring that they know how their facilities are performing. They also utilized the data that was coming from the assessments, and then they were held accountable in case there were some gaps that we knew as a facility they would address those ones. So they were involved for accountability, leadership, as well as ownership of the actions that were being supported. And then we also really did have done, over time, we have done a lot to support and also participate in the WHO hand hygiene campaigns. And during these campaigns, we have always worked with the healthcare facilities and the leadership to ensure that we pick out some people who are really committed to leading IPC and hand hygiene practices. We provide some incentives to motivate them, and then we also recognize some of them in a way. And that photo was really showing a time we were recognizing some of the champions, and this was done by their leaders who were seated at the front. Next slide.
So now we have
All
a
right, so we have,
Sorry, go ahead.
sorry, Nikki, go ahead.
If everyone could just scan the QR code, we have a bit of an interactive portion for a couple of minutes. There will be 2 questions, and your answers will pop up on the screen. You just scan this QR code up in the upper left corner.
Okay, so we wanted to hear from you, and what are some of the challenges you have encountered in your own spaces, hospitals, healthcare facilities, regarding mainly hand hygiene and improvement, IPC improvement. So share with us. This is what Nikki was meaning. Share with us so we can relate. We can learn from you as well. All right, so I see lack of supplies, which is a very, very common, it's a very, very common challenge, and it cuts across a number of hospitals, regardless. And then supply chain, okay, same. Staff behavior, yes, this is really, really something. This is critical. Behavior among healthcare workers and other people, really. When it comes to IPC practices, it is something that we need to really target and speak about our behavior. Because IPC is supposed to live with us. They are simple measures, but then people intentionally do not want to practice these measures, which is dangerous and which is a big challenge. Yeah. All right. So Nikki, you can move to the next question. We have another question. What strategies have been effective for you in your spaces? What have you used that has worked for you? Please share with us. And then we will move to the next. We are almost done. Yeah. Capacity building. Yes. Regular capacity building is one thing that really improves healthcare worker skills as well as knowledge. And then we have constant engagement of IPC committee. Yes, IPC leadership, as well as the leadership of the hospitals, actually collaboratively working together strengthens and improves practices very, very much. Capacity strengthening and supporting with IPC consumables, yes, very good. That is something that is important. It is something that we have seen that affects most of the practices because healthcare workforce don't have supplies, and so they just don't do anything. Use of champions, yes, these are some of the things that somehow trigger behavior. If healthcare workers know that they're going to pick champions next month, we try to do as much as possible to ensure that they are becoming as excellent as possible. So yes, that is one thing that I agree works. Quality of care, circuit riders, supporting ongoing training, staff practices, monitoring. Yes, monitoring and use of data is also something that is really important. Otherwise, it is not very possible if healthcare workers do not know what is coming from their facilities. All right, so Nikki, I think this is enough. We may need this later. Thank you so much for participating in that and for sharing with us your knowledge. Lastly, I think we have one more slide to go. Next slide. All right, so lessons learned. So what have been the lessons that we have learned from some of these strategies that we have shared with you? One, we know that local solutions really work, but they are only sustainable if leadership is in support of these solutions. If your leaders are not agreeing with what you're doing, then it is going to be hard to sustain or to continuously do or support the interventions. And then continuous training is essential, but not enough. It needs you to add supplies, the tools, add some maybe behavior change interventions, recognition, and so on and so forth. And then leadership engagement leads to ownership. Yes, and then monitoring and proper feedback improves performance, because you know that where we have data, then we are able to act on the data to improve actions. Next slide. Lastly, And like Maureen earlier highlighted, there's quite a number of documentation that has come from this work, what has worked, the strategies, the ABHR production, and you can really find these papers on the internet, on different journals, published in different journals. We shared the links with Nikki, and I think she's been able to share the links out widely. So feel free to check them out and read about them. So thank you so much. I think, Ryan, that brings me to the end. Back to you.
Yeah, thank you so much, Shillah, Maureen. This has been a really great presentation. So we have a few minutes left, and there's a handful of questions in the chat. So we'll answer as much as we can until for the next 5 minutes. But the first question I have here is, who checks the quality and standards of locally produced ABHR, and what is the frequency of monitoring?
Ryan, I'll take that very quickly. So it was input into the strategy for alcohol-based hand rub production. So it talks about what do we do in terms of setting up, and then what about quality assurance. So we have the internal validity and external validity. The internal validity of or quality assurance of alcohol-based hand rub is done by the producers themselves, and this is done per batch of alcohol-based hand rub produced. So if you, as a producer, produce a batch of ABHR, you conduct the quality assurance after 24 hours or 72 hours immediately. And then when it goes into health facilities, we understand that the literature says that it doesn't expire until I think 9 months or something like that, if I remember the numbers correctly. But then we do check the quality assurance tests every 3 months so that we see whether the alcohol content has reduced or it is still the same as at production. And so whenever we never observed any deterioration of quality or during the life cycle of the work we were doing, and we continue to encourage the IPC committees to monitor that. But for the time of implementation in our proof of concept, we never saw any deterioration or adulteration of the ABHR from production to expiry. Over.
Great, thanks, Maureen. And I saw you replied to Doris's question. She had several questions. Anything you want to just quickly say out loud on her question?
Yes, Doris, thanks for the excellent questions. And there's so much that we had to learn here, and there's a lot that is left to be done, especially within the LMICs. I think we have had a lot of mileage with the healthcare facilities, and this was especially because of outbreaks in our context, because we've had quite a number of outbreaks, COVID-19, Ebola, Mpox. So we have built some sort of capacity within the healthcare facilities, although it becomes suboptimal in peacetime, what we call peacetime. We have peacetime, which is when we are not in outbreaks, and wartime. But then we continue with the capacity building. But in the community locations is where we still have challenges, and you talked about use of ash, and use of other hand hygiene supplies. This continues to be seen in different places, and there's need for community interventions really to support the community health workers and others. And then finally, one last thing I'd like to comment on, Ryan, is how will this be sustained beyond the project, ensuring sustained commitment and funding from the government? I like to say that this project it ended around 2013, and we have continued to see sustainability through use. But mainly the challenge is around supplies. The good thing is that the raw materials for ABHR are within the supply list for the national medical stores. So these are supplies that normally go through the supplies chain to the health facilities. So the production is able to be sustained at the district once the district has bought into this intervention. We worked with the Ministry of Health to regularize this initiative, but this is still a work in progress. Thank you.
Thanks, Maureen. Well, thank you again for your excellent presentation. This was really exciting and engaging. A few final announcements. Just remember to sign up for our working group on faith-based organizations. Sign up for our webinar, which will happen in actually just a few weeks in early May. And sign up for our newsletter, where you can get all this information in case you miss the links, and to stay up on all things Washington healthcare facilities. I'll give everyone a second to grab those links. It looks like Nikki just dropped them in the chat, but thanks again, and we will see you in May. Take care, everyone.
Thank you.
Thank you, Paul.